Hello, I'm Dr. David Levine. Today's date is May 24th, 2025, and I'm at the Lost Pines Resort in Austin, Texas for the American Association of Plastic Surgeons meetings, where I'm conducting interviews for the ICON Project. The purpose of the ICON Project and these interviews is to preserve in an audiovisual format icons of our society who are teachers, innovators, forward thinkers, and great surgeons who advanced our specialty to where it is today. I hope you enjoy this. Hello, I'm Dr. David Levine, and welcome back. Today I'm here to interview Dr. Andrew Lee. Dr. Lee, thank you for coming, sir.
Good to be here.
We had a little bit of talking before, but now we'll get into the interview itself. But would you state your full name?
Wei Ping Andrew Lee.
Okay. And date of birth?
June 7th, 1957.
Okay. Would you tell us your parents' name and a little bit about them?
Sure. My father's name in Chinese is Li Xueyan, or Xueyan Li. He has had quite an illustrious career. He started out in China Air Force. He was born in a very poor family in southern China, joined the Air Force, or the Nationalist Air Force, I should say. And he flew a bomber during World War II, during the Japanese invasion of the Chinese mainland. In fact, he was quite prominent in flying some risky missions to meet with the communist leaders at that time. Eventually, when the communists took over the mainland in 1949, he and my older siblings, and my mother, of course, moved to Taiwan. And that's where I was born and grew up. And my mom, her name is Zhang Zuqing, or had an English given name of Nora Chang. And she was a newspaper reporter. She met my dad in Sichuan, where she's from, because that's where the nationalist government was at that time. So they got married, and after being a journalist for a while, she became a full-time housewife, including, of course, the time that I was growing up. And I remember her fondly for cooking her native Sichuanese food. And to this day, the spicy Sichuanese cuisine is still my favorite.
Wonderful, wonderful. And did you have any sisters? You have sisters or brothers?
Yeah, they're all older than I am. I have one brother and 3 sisters. They actually played a very important part of my growing up. So my parents decided when I was 15 to send me to the U.S. to get a head start on American education, partly because all my siblings were already in the U.S. So they figured that by coming here early, I could, again, get a jump on the education. So I was staying with my brother and the sisters at the time. And in fact, because they were finishing graduate schools and taking up new jobs in the U.S. around the country, so I stayed with them and ended up moving every year. So my bragging right is my first 4 years in this country, I went to 4 different schools. Had a new environment every September.
And what part of America did you move to?
So I started out in the Midwest, in Champaign-Urbana, Illinois. That's where U of I is. My second sister was graduating from there. That was quite an experience because at Urbana High School, at that time, this was early 1970s, there was no one else who looked like me. I was the only person, and I was a complete outsider, not just culturally, but also linguistically and socially as well. So I think those years had a great impact on my career, on my life, because I had to really adapt very quickly to a brand new environment. And I think in retrospect, I learned a few things during those years that really benefited me for the rest of my career.
And after you graduated high school, did you go to Harvard?
I went to Harvard College, yes.
Okay. Assume you don't have any grandchildren yet, or do you?
No grandchildren. We have three wonderful children. They're in different parts of the country. Our older son is a special needs adult. He is in Pittsburgh and doing well. Then I have a daughter who is with me in Dallas. She works as a psychological counselor. And our younger son is a software engineer and currently a chief technology officer in New York City for a company.
Wonderful. Okay. And we talked a bit about this, but would you say a few words how you met your wife and whatever you
Sure.
want to discuss about that? I'm
Sure.
in your comfort.
So Terry and I met actually my last year in high school. Her family at that time were in Princeton, New Jersey, and my brother, who took a job, as I say, I was moving around with them, just took a job at the Princeton Plasma Physics Laboratory. So I was in the same class as Terry's sister, so we got to know each other then. And we got married a few years later. And as I mentioned, we had three children that we're very proud of. Unfortunately, Terry's family has had a history of pancreatic cancer. And she was diagnosed with pancreatic cancer about 4 years ago.
I'm sorry.
And we eventually lost her to the condition last July. True to her personality, she was very brave. I will say had a very positive attitude in battling the cancer. We had all the treatment, the surgery, chemotherapy, radiation therapy, immunotherapy, etc. Really remained optimistic throughout her entire course, even until the very end.
Well, you were kind to share that with us, and thank you. What inspired you to go into plastic surgery? I want to know about your mentors, but I want to know a little bit about the procedures that you've done that changed the paradigm of plastic surgery. And it's always fun to interview somebody that is the first, the point zero of that.
Well, going back, I must say that unlike some of my junior faculty or even resident today, my career choice was not necessarily based on scientific analysis or deep soul searching. My minds were quite open in medical school about specialties. I liked a number of fields, but eventually I think it was the junior faculty and the plastic surgery residents I had a chance to work with. I thought that they were technically superb, and they were good human beings. They interacted well with one another. So I thought I want to be like them. So I'm not sure that's necessarily the best way to make a career choice, but that's what happened in my case.
Okay. And the mentors that you had early on in your career, who would they be? The few that are at the top of the list.
Yeah. I want to answer the question a little differently.
Okay.
So certainly there were a few people who had great influence on my career. But I think one of the things I've been able to do, maybe because of my need to adapt to the culture and the society, was for me to watch each person I interact with very closely, to see whether we're doing right, what their attributes were, so I could emulate them. So I'm not sure I can point to a few people necessarily, but really a group of people. Having said that, in my presidential address last year to the association, I did mention three people whose traits I emulated. Dr. James May, my boss at Mass General Hospital, Dr. Jim Strickland, who headed my hand surgery fellowship, an orthopedic surgeon, and Dr. Tom Starzel, the father of liver transplantation. So I learned something from each of them. But I would say really it's a broad group of people, and not even just my senior folks. I learned, I think, from my colleagues. I even learned from my junior faculty as well.
Okay, good. And the next question, and now you have to approach what one of the things you did, you're known for many things, so I'm not going to box you into this one deal, but you see momentous paradigm shifts in plastic surgery during your career, and I know you're not near finished. And like I said, maybe in 10 years we'll do a follow-up. I hope I'm around anyway.
Of course.
Tell us a little bit about them, and tell us about your, because this was world news. And when you do this, it brings plastic surgery to the forefront and tells people we don't just do facelifts and rhinoplasties and skin care. We do other things, but your bilateral hand transplantation, your mid-humeral, and anything else that you might be considering, and just in a few minutes, you don't have to get into the detail of it per se.
Well, I would say as a field, plastic and reconstructive surgery has had a long history of developing novel treatment for wartime injuries. So dating back to 1943, way before my time, during World War II, Valley Forge General Hospital was stood up to treat those horrendous injuries from the war. Dr. Brad Cannon, Joe Murray, James Barrett Brown were very
Dr. Blair.
Right. So I think plastic surgeons reacted to difficult injuries and innovate from it. So along the same paradigm, if you will, the wars in the 2000s, the wars in Afghanistan and Iraq, brought home a large number of wounded warriors with extremity amputation. The reasons are twofold. One is body armors were developed that were able to protect our warriors' trunk, yet the extremities were exposed. And secondly, the advance in field resuscitation was such that a lot of those injured soldiers and Marine were kept alive, and yet again came home without the upper or lower extremity. And that really prompted our team to think deeply about hand and arm transplantation. There had been a few that were done at the time. They tend to be restricted to wrist level and usually single or unilateral or transplant. But of course, wounded warriors had no choice in terms of the nature of their injuries. So we have many wounded warriors with bilateral amputation and sometimes amputations above the arm. In the meantime, our laboratory had been interested in developing immunomodulations to minimize the amount of immunosuppressive drugs necessary to treat the recipients of hand-arm transplantation. I mentioned Dr. Tom Starzl earlier, and we were in Pittsburgh at the same time, and he really encouraged us to pursue hand-arm transplant. So with support from the institution and from the Department of Defense, we established a hand transplant program, and I was very fortunate to work with a group of colleagues, not just in the laboratory, but also in clinical medicine to put together a hand transplant team. This is a team that required collaboration of specialists who usually did not work together. So just in hand surgery itself, we have, of course, plastic hand surgeons, orthopedic hand surgeons. We need microvascular expertise, and we need transplant surgeons who know how to manage a transplant recipient. But quite outside the field of surgery, we need the various medical specialists, the nephrologist, the infectious disease doctor, sometimes the cardiologist. And then even beyond medicine, we need mental health professionals. So a psychiatrist, psychologist, and not to mention all the other critical personnel like social workers, specialized nurses, hand therapists are critical. So we were fortunate in putting together a very large team, and were able to treat a number of the wounded warriors. And I think we took great gratification in being able to change their life. An easy example is when you are a bilateral amputee, you really couldn't do very much yourself, whether it's eating, dressing, or even going to the bathroom. So a lot of times, those patients needed a personal attendant just for their everyday living. And what we were very pleased to see is after successful bilateral transplant, we not only restore their functions, including sensation, which prosthetics do not deliver, but also restore their personal autonomy so they can live by themselves, as many of them have currently.
You know, you brought up something which you mentioned, but is so important whenever I see a wounded warrior, is the psychodynamics
Absolutely.
that they go through. And Edgerton was really one of the first to think of that. When he came to UVA, he brought the Department of Psychiatry, which the general surgeons really liked, because he brought, and part of his thing was to interview patients and get in their heads. So far ahead of his time.
Yeah.
And I think about those people, and you have to address from here up and then out that way, and it's multidisciplinary, and you know, that's fantastic, you know.
I think you hit on a very important point, and this was one of the hard lessons we learned from our hand transplant experience is patient selection. You have to select patients with the right motivation and also good family support in order to have a good outcome. So when those conditions were met, patients did well. But if they're not motivated themselves or they didn't have the proper infrastructure or support in the family, the results tended to be less good. So we paid a lot of attention not just to the patient's psychological well-being, that's why psychologists and psychiatrists are so important, but their family support. We always interview the family before we decided to do a transplant.
Well, it's never easy, is it? What my next question, and I think you really answered what's been the most important innovation in our specialty. And to me, what you did or doing is what most of my icons in the last couple of years have talked about, microvascular anastomosis, et cetera, and all that goes with it.
You know, I want to make a point about innovation, not necessarily singling out one or two, innovations in our lifetime, because I think there are a number of potential candidates, but really the importance of innovation for a field like plastic and reconstructive surgery. So as we know, plastic surgery does not have exclusive claim to an anatomic area, to a physiologic system, or a patient population, which I would say all the other specialties do. So what happened a lot of time when we innovated and established new procedure in the area, other specialists came in and took over. And you can think of many examples, so I can. Hypospadias used to be a plastic surgeon's operation, not anymore. Head and neck reconstruction used to be a plastic surgeon's operation. There are a few plastic surgeons who do that, but our otolaryngologist colleagues are doing the great majority of that. So I think innovation for a field like plastic surgery is particularly important. It is the essence of our field, but quite frankly, it's also a way for us to survive.
Well, what you just said is we're always going to have turf battles.
Yes.
Because we come up with the idea,
right,
and everybody wants to get on the boat, but it's never that easy. The boat has to be run by several people, and I appreciate your comment that your philosophy that you have to have a team that contributes to that well-being of the patient for a successful outlook. So,
philosophically, I wouldn't draw the line too harshly between plastic surgeons and other specialists. My field of hand surgery, of course, orthopedic surgeons participate in it. And there are some areas they do better than we do, and in some areas we do better than they do.
Yeah.
So my attitude toward what you call turf battle is whatever is good for the patient.
Right. I agree with you. Yeah. But sometimes we still get into it.
We still do. But I think that the mindset should be what's good for the patient. That's at least in my view.
Well, Andy, you've done so much, but I'm going to ask you this. And what do you feel your greatest professional accomplishment is?
I'm not done yet. But I would say that to be able to work with a team of talented and motivated individual, coming from different specialties to achieve something that had not been done before, I think is most meaningful to me.
Okay. What do you think the greatest mistake our specialty has made?
So we're going to change subject areas. And this probably gets to a different dimension of plastic surgery. I think one mistake that plastic surgeons, or I should say academic plastic surgeons, have made in the last few decades is complacency with the division status in the academic center within the Department of Surgery or General Surgery. Knowing how medical schools and academic medical centers work, I think plastic surgeons need to have greater autonomy in determining their resources, their direction, and how the institutions invest in plastic surgery. Being a division of general surgery, I think could work out in some instances, but in general, as I mentioned before, quoting a cliche, if you're not at the table, you're on the menu. Many general surgeons, chairs of surgery, don't fully understand plastic surgery. And when it comes to allocating resources, they have other priorities: vascular surgery, endocrine surgery, GI surgery, you name it. So plastic surgery does not necessarily rise to the top. Other surgical specialties, such as neurosurgery, orthopedic surgery, otolaryngology, and urology, understood that point decades ago or more recently. And most of those specialties now have departmental status in medical schools and not be part of general surgery. Still a couple exceptions, but I think plastic surgery, by and large, remain divisions in departments of surgery across the country. Again, there are exceptions, and I'm happy to cite them. They happen to be all doing very well. But I think that's one area that we really need to think very seriously about, because as I mentioned in my presidential address last year, I think departmental status is something that plastic surgery deserves and plastic surgery needs in order to advance the field.
Okay. And just, what is your official position at Southwestern? I looked through that, but I saw many things, so.
I really have two roles. So I serve as the Dean of the UT Southwestern Medical School. So I oversee 21 clinical departments, 12 basic science departments, and another 10 autonomous research centers. But I wear another hat of Provost of UT Southwestern
That's what I saw. Okay.
Medical Center. So provosts also oversee different schools. So in addition to the medical school, for which I'm the dean, I also oversee our School of Public Health, our Graduate School of Biomedical Sciences, and our School of Health Professions.
Okay. Well, I'm impressed that you only need 3 hours of sleep a night based on what you're telling me. But
well,
no, I mean, that's amazing. That's a lot of work. A lot of the buck stops at your desk, though.
I'm not sure about that. You know, it gets back to the team, right? I have a great team of people with trust. We openly discuss, we openly disagree, and I delegate a lot of responsibility to team members.
What has been your greatest joy?
Well, aside from spending time from my family, I would say I enjoy music greatly. I have a very eclectic taste, but I would say opera music is probably something I enjoy the most. My residents tell me I'm the only attending who plays opera music.
And they must hate your guts for that.
Well, I'm convinced playing opera music make the residents operate faster.
Oh, see, you play an instrument?
No, I don't. I took some violin lessons when I was growing up, but never got much of it. But I think going to operas or just listening to opera, classical music is probably what I do the most, enjoy the most.
Okay, next question is a dual one that you can answer it either way. Do you admire most, and professional or personal? You decide.
Yeah, well, that's a pretty open question. As I mentioned, there have been great role models for me throughout my career in plastic surgery or in medicine. So I'm going to go in a very different arena. and that is in the world of politics. So when I came to this country, again, this was in the 70s, I started following American politics very closely, and student of the American democracy. One person I have admired, and I even have an autographed picture of him in my office, is Ronald Reagan. He is someone, I think, with principles. He had a vision. He had the skills and ability to be a leader. I think he did it with style, great communicator, a lot of other skills. And he also had impact on the world. So I think no matter your political philosophy, those characteristics of him make me a great admirer of Ronald Reagan.
Okay, well, that's interesting because I never would have thought you would go into I never thought so much about politics the last 8 years, I have to admit. I forgot when I took civics, but I didn't learn much. But I've learned a lot now, and it's not all good.
It's not all good. Yeah.
Would you give us words of wisdom for present and future generations of plastic surgeons?
The world's changing. Academic medicine is changing. Let me give you 2 examples outside plastic surgery. I was talking to my student deans about lectures for medical students. Only about 5% of medical students come to listen to lectures in the pre-clerkship phase. That is the first year and a half in our medical school. The rest of them either stay home and watch the recorded video, or they actually watch something else on YouTube. So learning habits for medical students has greatly changed, and I think that has implication on the rest of us in medical education and practice of medicine. Speaking of practice of medicine, radiologists don't come to the hospital and sit in front of the board and put out those x-rays like you and I are used to. In fact, they don't come into the hospital because they have workstations at home.
They have a portal.
Exactly. So my radiology chair tells me we have to hire them to work remotely. So now all of a sudden the job is open to everyone around the country. So I'm using those 2 examples to make the point that technology and maybe attitudes of people are rapidly changing, and that's going to affect plastic and reconstructive surgery as well. So artificial intelligence, obviously.
Yeah, that'll be, I think, big part of radiology.
Well, I don't think it's radiology. I just got a request for a pathologist to work remotely. So now, plastic surgery, I don't think can be done remotely, but still, I think the way people are approaching the practice of medicine, the telemedicine, obviously, is getting more popular. I think the field is going to undergo significant changes, even plastic and reconstructive surgery. And we better continue our tradition of innovation to stay ahead.
Okay, so we're getting toward the end of the interview, and I'd like to know what your predictions are for plastic surgery in the next quarter century.
Okay. Well, as Yogi Berra said, it's always hard to make predictions, especially about tomorrow, let alone the next 25 years. This is what I think about plastic surgery to a point that I already made. Plastic surgery is an elite subspecialty for the brightest and most innovative. And yet what we do clinically or even in research are often poorly understood by our brothers and sisters outside of plastic surgery. I mentioned the importance of innovation. I think for the field to survive and in fact distinguish itself in the future, it must go back to the tradition of research, innovation, and discovery in order to truly advance the field and make impact for our patients. I'm not sure I can predict what will happen, but I do think that's the direction that the field needs to go.
Okay. Is there anything else you want to add that I might have asked or not asked, or something otherwise we're at the end of the interview.
No, I don't think so. I think we covered a lot of grounds. Thank you very much for the thought.
Andy, what a pleasure. What a pleasure to
Same
meet
here.
you.
Likewise.
Stay safe in Dallas. I'm in Fort Worth.
Oh, is that right?
Yeah.
Oh, okay.
Yeah. Thank you for watching, and I hope you enjoyed this interview. All of my interviews are available online at meeting.aaps1921.org. Again, that's meeting.aaps1921.org. And thank you.